You know, if you've ever stood at the foot of an ICU bed, you absolutely know the feeling. The rapid, rhythmic beeping of the mechanical ventilator. It can be incredibly intimidating. You're staring at this monitor filled with jagged green, yellow, and blue lines, and you just know. The machine is trying to tell you something absolutely critical, but it's like it's speaking a totally foreign language. Well, welcome to this explainer. Today, we're going to change all of that. Consider this your personal medical detective's guide to translating that language. We are going to decode exactly what those waveforms are trying to tell you so you can step up and intervene quickly and confidently.
Okay, let's dive right into this. Here's our agenda for today. First, we'll cover the 3 basic waveforms. Second, we'll get into troubleshooting common vent problems. And third, we'll finish up by decoding ventilator loops.
All right, Part 1, the 3 basic waveforms.
So, to spot any weird anomalies, we first need to establish the baseline behavior of our primary witness, the ventilator itself. The very first curve we look at is the pressure curve, which, as it sounds, tracks airway pressure over time. Now, notice it doesn't actually start at 0. It usually starts a bit elevated with a little bit of PEEP. That's positive end expiratory pressure right at the baseline. If you're running the vent in pressure control mode, you're going to get a somewhat squared-off shape. But if your patient is in volume control mode, this curve takes on a really distinct, sweeping shark fin appearance. That visual shark fin, that's your immediate dead giveaway for the mode you're operating in.
Next up is the flow curve, which you'll often see signified by a V with a little dot on top of it. This shows the flow of air over time. The breath kicks off with a sharp, positive increase on the inspiratory limb that kind of gradually tapers off. Then, it drops down below the line to become the expiratory limb. Now, I need you to burn this next detail into your memory. That expiratory limb absolutely must return to the 0 baseline before the next breath begins. Seriously, we're going to come back to this, because whether or not this curve reaches the baseline is basically the key to solving our most common vent mysteries.
And finally, we have the volume curve. This one is actually super straightforward. It literally just displays volume over time. What you're looking at here are visual peaks that correspond perfectly to the actual inspirations of your patient. Air goes in, the curve goes up. Air goes out, the curve goes down. Simple as that.
Moving on to Part 2, troubleshooting common vent problems. Okay, now that we know what normal looks like, the real detective work begins. We're going to hunt down the 4 main culprits that cause our patients distress and trigger those blaring alarms. Suspect number 1 is air trapping, and wow, is it a common one. Remember how we just said the flow curve absolutely must return to baseline? Well, in a normal flow, the expiratory limb comes all the way back up to that 0 line before the next breath kicks in. But in air trapping, the patient takes an inspiration, goes into the expiratory limb, it starts heading back, and boom, the next breath initiates way too early. The flow completely fails to reach the baseline. The machine is essentially shoving more air in before the previous breath is completely emptied out.
We typically see this trapping in patients with severe obstructive airway diseases. Think emphysema, COPD, or asthma. So how do we apprehend this culprit? We actually have a few actionable steps here. First off, we can administer bronchodilators to actively open up those constricted airways. Next, we need to manipulate the I to E time, right? That's the ratio of inspiration to expiration. We want to decrease the inspiratory time, usually by increasing the flow so the air rushes in faster. That, in turn, increases the expiratory time, giving all that trapped air the precious extra seconds it desperately needs to escape. So the crucial point is, why do we manipulate the flow instead of just, say, decreasing their respiratory rate or tidal volume? Well, dropping the rate or tidal volume would technically fix the I to E time, but we actively avoid doing that because it really negatively impacts the patient's overall minute ventilation. It's just so much safer to push the air in quicker to give them more time to exhale.
Let's move on to our second suspect, breath stacking. You might also hear this called double triggering. A completely normal breath shows a single, distinct peak on both the flow and the volume curves. But with breath stacking, you'll see a normal breath and then instantly 2 quick breaths in immediate succession, stacked right on top of each other. The patient is literally double triggering the machine. And this happens for a really simple reason. The patient is demanding more air than the machine is currently giving them. When we see this double triggering, it usually means the tidal volume is set too low for what the patient's brain is asking for. A lot of times in the ICU, we use low tidal volume ventilation strategies. We're talking targeting around 4 to 6 cc's per kilogram. But if your patient is breath stacking on that setting, they are very unhappy. The fix here is to increase the tidal volume target up to 6 or maybe even 8 cc's per kilogram. You really want to satisfy that air hunger. Because if you leave breath stacking untreated, You drastically increase the patient's risk of dangerous complications like volutrauma and barotrauma, and nobody wants that.
Now, what's really interesting about this next slide is how we investigate our third culprit, air leaks. This is where we have to start cross-referencing our clues. You might spot an issue on the volume curve, where the expiration drops down but suddenly hits a dead zone. It just doesn't return to the baseline. The machine pushed air in, but it couldn't detect all the air coming back out. To figure out the actual cause of that missing air, we have to pivot our investigation over to the flow curve. If the flow curve is showing signs of air trapping, well then there isn't an actual physical leak in your tubing, the air is just trapped inside the patient's lungs. But if the flow curve looks perfectly normal and beautifully reaches baseline, yet the volume curve still shows a leak, that tells you there is a true system leak. The air is physically escaping somewhere else, maybe from a cuff leak or potentially even a pneumothorax in the patient's chest. Our fourth and final troubleshooting suspect is flow hunger. This one is highly visual. Instead of a nice, smooth pressure waveform, you get what is perfectly described as the camel bump sign. I mean, the pressure wave literally looks exactly like the two humps on a camel's back. This anomaly happens because the patient is vigorously trying to suck in more flow than the ventilator is actually providing. The fix here is just as simple as the diagnosis. You just need to provide the patient with additional flow to meet their demand. Easy.
Okay, so we've mastered the basic curves, and we've caught the most common culprits. But what if those three basic timelines just aren't giving us enough information? What if we need to dig a little deeper into the patient's lung mechanics to crack a really complex case? That brings us to part 3, decoding ventilator loops. By taking the parameters we've already learned and graphing them against each other instead of just against time, we unlock our most advanced diagnostic cheat codes. First up is the flow volume loop. Now, a normal loop has a nice smooth inspiratory curve above the axis and a smooth expiratory curve below, but we are looking for the weird stuff. If you see a jagged, scratchy appearance specifically on the expiratory limb, your prime suspect is excessive secretions in the patient's airway. Basically, they need to be suctioned. Now, if that scratchy appearance is on the inspiratory limb, you likely have excessive fluid condensation trapped inside the ventilator tubing itself, which you'll need to dry out. And finally, if the loop has a heavily scooped out appearance on expiration, you are looking at severe airway obstruction. We're talking a massive asthma or COPD exacerbation.
Next, we examine the pressure-volume loop. A normal baseline loop looks somewhat like a tilted leaf, which usually corresponds to a normal PEEP of 5. And this brilliantly illustrates exactly how stiff or stretchy the patient's lungs actually are. By simply looking at the physical tilt of this loop, you get instant visual feedback on lung compliance. If the leaf shape shifts to become more upright, kind of jumping toward the volume axis, it indicates improved, highly compliant lungs. Conversely, if the loop starts to lay down and become more flat toward the pressure axis, you are dealing with decreased lung compliance, meaning stiff lungs that require a whole lot of pressure just to push a tiny bit of volume into.
So when you're looking at the pressure-volume loop, remember that the standard leaf shape is your normal baseline. If that leaf suddenly becomes much wider than normal, it signals increased airway resistance. But the two most famous visual mnemonics here are the fishtail and the bird beak. If the bottom of the loop dips backward before going up, creating this fishtail appearance, it means your trigger isn't sensitive enough, and the patient is working way too hard just to initiate a single breath. On the flip side, if the top of the loop tapers off to a sharp point, creating a bird beak appearance, you have alveolar overdistension. Your pressure or your PEEP is set way too high, and you are dangerously overstretching the alveoli without getting any extra volume for it. If you see a bird beak, you need to back down on that pressure immediately. Wow, we've covered an incredible amount of ground today, from the simple shark fins of the pressure curve to hunting down air trapping and breath stacking, all the way to diagnosing overdistension with the bird beak on a pressure-volume loop. You now possess the visual vocabulary to understand exactly what the machine is trying to tell you. The monitor is no longer just a box of intimidating alarms, right? It's a vital investigative tool. You are now equipped to crack the case for your patients on your next ICU shift. Keep this explainer handy, but before we go, it begs a much larger question. As medical technology continues to advance, what other subtle, hidden languages are the machines in your hospital speaking right now, just waiting for you to translate them? Keep learning, keep asking questions, and I'll catch you next time.